Welcome. My name is Piero Tartaro, and I'm a gastroenterologist at Sunnybrook Hospital. And welcome to this module on an approach to nausea and vomiting. I have nothing to disclose with respect to this module. So our end-of-week objective is to describe an approach to nausea and vomiting. The module objectives are for you to be able to define nausea and vomiting, describe the pathophysiology of nausea and vomiting, be able to provide a systems-based differential diagnosis for nausea and vomiting, to describe general management for patients with nausea and vomiting, to understand the role of empiric therapy for nausea and vomiting based on knowledge of neurotransmitters, and to recall the role, names, and mechanism of action of prokinetic agents. So first of all, some definitions. So nausea is something we all sort of are aware about and use in everyday language, but it's important to understand the actual definition if you're ever helping a patient understand or try to really tease apart what they're complaining about. So nausea refers to an unpleasant subjective sensation of being about to vomit, and it may be present with or without vomiting. So patients with vomiting generally have this symptom of nausea, but there's many patients who just have nausea but don't actually have the act of vomiting. So vomiting, by its definition, is that there's actually the forceful, reflexive expulsion of gastric contents through the mouth. So some other symptoms that we use that's important to be aware about in terms of their definition is retching. So retching is similar to vomiting, except no material actually comes out. So the may be going through that forceful, expulsive sort of maneuver, but actually no contents are delivered through the mouth. Regurgitation is something I find that often either patients and sometimes physicians confuse, and it's important to be aware because the approach to these symptoms can be very different. So regurgitation is actually the perception of flow of reflux gastric contents either into the mouth or to the hypopharynx, which, as opposed to vomiting, is actually without force. So this is more, I don't want to say spontaneous, but there's not that forceful reflexive motion that goes along with it. And it's often not repetitive like vomiting is. So when thinking about the pathophysiology of vomiting, there's really two systems we need to sort of focus on. One is the central nervous system, and the other is the gastrointestinal tract. And really, we're actually going to be focusing a lot today on the central nervous system. So the vomiting reflex is an important thing to be aware about in terms of understanding why vomiting occurs and what causes vomiting and how we treat nausea and vomiting. So the sort of final product of the vomiting, or sort of the main sort of center is the vomiting center, as it's referred to. And it's really the control center located in the medulla of the central nervous system. And it's responsible for having all the efferent output of the vomiting motor sequence, and all the afferent or the input goes to this vomiting center. So again, all the inputs come to here, and then all the outputs go out of the vomiting center. That is the crux of the vomiting reflex. So in the end, it represents this sort of final common pathway of all the inputs that can cause vomiting. And it's located in the medulla within something we call the nucleus tractus solitarius. And just more for you to be aware of this location. So the inputs into the vomiting center are all part of this vomiting reflex. And the various afferent inputs include the chemoreceptor trigger zone, which you'll see commonly. This is located in the area referred to as the area postrema. Really, this is important is because it's actually located outside the blood-brain barrier. So it's actually able to sense things that aren't able to penetrate the blood-brain barrier. And it can be triggered by things even within the CNS, but also things without the CNS that are blood-borne. And that can include things like drugs and metabolic and endocrine states. There's also triggers from the cerebral cortex, and this can be triggered by things like anxiety or anticipated nausea. So, for example, someone be really worried about an exam or a job interview may have a sensation of nausea, and this likely triggered through the cerebral cortex. There's also various afferent inputs from the visceral organs, and in particular the GI tract, but also things even like the heart. And this often is being transmitted to the vomiting center by the vagus nerve. There's also midbrain intracranial pressure receptors, and this is often triggered by raises in intracranial pressure, such as masses within the central nervous system, or hydrocephalus, or other conditions that basically increase the intracranial pressure. Then the vestibular system. So this is triggered by such things as inner ear disorders or by such things as drugs like morphine or infections, when people have sort of motion sickness, like when they're on a cruise, on a boat, on a roller coaster. These are various sort of causes of nausea and potentially vomiting that are triggered through the vestibular system. But all these, again, input into the vomiting center, which is located in the medulla, and that then sends its sort of triggers. So there are various neurotransmitters to be aware about. Include serotonin, and the particular receptor that's being involved is 5-HT3. This is particularly important in GI tract disease. Dopamine, and this particularly with respect to the dopamine 2 receptors. There's a substance or a neurotransmitter called substance P, and the receptor associated with this is neurokinin 1. Acetylcholine, which you learn about in lots of different conditions and different pathophysiological states, is important for the vomiting reflex, in particular with the muscarinic 1 receptor, and that's M1. And also some of the diagrams you'll see, they also refer to this as ACHM, and that's why I've included this short form as well too. But basically I'm referring to the same thing. And this is particularly important, particularly for vestibular disorders. Then there's histamine, particularly histamine 1 receptors that are important. And obviously we talked about histamine in other conditions such as acid production in the stomach, and that's more with histamine 2 receptors. But the histamine 1 receptors are particularly important with vestibular disorders. So all 5 receptors are present in the chemoreceptor trigger zone, but in that zone, the 5-HT3 and the D2 receptors seem to predominate, and that will become important when we talk about pharmacotherapy. So this is a simplified overview, which in some ways is not so simple, but I think really helps sort of show what I've tried to allude to on the previous slides. So this is, again, the vomiting reflex. So on the left, you see the vomiting center in the middle, where histamine 1 and the muscarinic 1 receptor, or the acetylcholine muscarinic receptor, tends to be most prevalent. And that's sort of the final common pathway. But then you have inputs, which can be from the cortex, from the vestibular apparatus, from the chemoreceptor trigger zone, and from various sort of visceral stimulation, such as from the gastrointestinal tract, via the vagus nerve. And on the right, you just see a representation of the area post-rema, which is where the chemoreceptor trigger zone is located. And this is outside the blood-brain barrier, so it's able to sense things that come from the blood, such as various metabolic abnormalities or drugs. So when we think about our approach to nausea and vomiting in terms of developing a differential diagnosis, this will really be guided by your history and physical examination. And during this module, the goal is not to go through every single question you need to ask on history and every single thing you need to do on physical, because this is something that will come over time by learning the various conditions and how they present. But really what I want to focus on is you being able to have an overall approach that you can build upon as you sort of gain more knowledge and experience. One of the things that really can help you clinically actually is also knowing, is this someone presenting acutely with vomiting, or is this someone who has a long-standing history of chronic or chronic recurrent vomiting? And your differential will be tailored to that sort of presentation as well too, on top of other factors. But again, let's just focus on a basic approach, and this will then fall into how I'm going to categorize things, which is into, is it a gastrointestinal cause? Is it a central nervous system cause? Or is it one of those other causes? And you can see, thinking of the pathophysiology, where we're really focused on the role of the CNS and then the contribution of GI tract and some of these other things, how this all fits in. So thinking of the gastrointestinal categorization, various ways of approaching this. So this is just one way that I think is quite useful. And follows the Medical College of Canada format as well. So you can think anatomically. So you have your esophagus, then your stomach, then your duodenum, followed by your intestinal tract, including your small bowel and colon. Then you have other sort of organs that contribute to your gastrointestinal tract, including the liver, the biliary tree, and the pancreas. You have what surrounds the abdomen and the gastrointestinal tract, which is your peritoneum. And then another category, which is called functional gastrointestinal disorders, which you'll learn about in a subsequent self-learning module, which are basically disorders of the gastrointestinal tract that are chronic and without any obvious structural or biochemical abnormality. And within particularly the non-functional categories, you have various conditions which may be inflammatory, they may be infectious, they may be obstructive. For example, within the esophagus, stomach, duodenum, you could have gastroenteritis, which is an infectious disorder of the upper GI tract, which could present with nausea and vomiting and maybe even diarrhea. Or you may have a blockage of the pylorus from peptic ulcer disease, which would be a mechanical obstruction. Or you may have a motility disorder of the stomach where the stomach is basically lazy, and that would be gastroparesis. And all of these can present with vomiting. So again, that gives you an example of infectious or inflammatory pathology, as well as mechanical and motility-related pathology. And within each of those categories, you can think of the various causes. So again, just a general approach, thinking gastrointestinal, thinking through the anatomical gastrointestinal tract, both the luminal and the extraluminal or accessory organs. Think about the peritoneum, the functional disorders, and then various types of pathology that can occur, like infectious, inflammatory, obstructive, and whatnot. Next, moving on to central nervous system. Here, again, it's just one way of categorizing things based on the Medical College of Canada. So you can have various things that increase the intracranial pressure, such as infections, trauma, tumors, and hemorrhages. You can have conditions that affect the vestibular system. And this obviously is one of the inputs into the vomiting center, for example, labyrinthitis. You can have various lesions within the brainstem as well, which can include tumors, which can lead to vomiting. And then there's various things that likely contribute to vomiting via the cortex, and these are more psychiatric or psychological conditions, such as anxiety states, people with eating disorders as well, which are obviously complex disorders that you'll learn more about during your psychiatry and pediatric learning. Then there's just a grab bag category that is just labeled as other. And I really highlighted here what I think are the more important and the more common categories, which again is really mimicking what's also with the Medical College of Canada. So this includes endocrine and metabolic abnormalities, and you just finished your endocrine block. So people with diabetes mellitus may have vomiting related to the hyperglycemic state. In addition, this also in a more complex way, diabetes contributes to vomiting, but via the development of gastroparesis due to autonomic neuropathy related to complications of long-term, particularly poorly controlled diabetes. But just a hyperglycemic state itself would be one of those other categories. Patients with hypercalcemia, as you likely learned in endocrine, can present with vomiting. Pregnancy, uremia, which is basically a state of renal insufficiency, and Addison's disease, which is a cortisol deficiency, which you would have learned about during endocrine as well, can all present with vomiting. Any state of sepsis, whether it's, for example, an infection of the kidney, we refer to as pyelonephritis, or even lung infections like pneumonia can have predominant GI symptoms as well too, including vomiting, or even bloodborne infections. If the patient's bacteremic, vomiting may be a feature. Various drugs and toxins, and obviously this is often due to its impact on the chemoreceptor trigger zone, which is outside the blood-brain barrier. Obviously chemotherapy being the most well-recognized one, but many drugs have gastrointestinal side effects, including symptoms of vomiting, which may not be a direct effect on the actual gastrointestinal tract, but may in fact just be its effect on the chemoreceptor trigger zone. And then another, again, miscellaneous category within the other category, which I know gets complex, but I just want to highlight myocardial infarction as being, if someone presents acutely with vomiting, that is obviously a diagnosis that would not want to be missed. So thinking through your approach to vomiting, we've talked about some of these things. So we're going to try to identify the likely cause of vomiting through our history and physical examination, and that's going to help guide our investigations. And we just talked about the various categories of sort of main systems-based approach to nausea and vomiting. The next is thinking back is, okay, this patient's vomiting, and somewhat irregardless as to maybe the underlying cause, what are some of the consequences of vomiting? So has the vomiting led to depletion of electrolytes like sodium or potassium or magnesium? And has the patient lost so much volume through vomiting that they are dehydrated and require potentially oral rehydration, or even potentially if they're really severe vomiting with quite severe volume depletion, that they may require hospitalization with intravenous fluid administration? The next thing is, okay, we're now have sort of dealt with what we think is the potential cause. We've dealt with some of the consequences of vomiting. How do we approach the treatment? And again, each specific cause will have its own specific treatment. And so if it's due to bowel obstruction, the patient may require decompression with a nasogastric tube, or they may require going to the operating room to remove whatever is causing the obstruction, such as clearing any adhesions that are there or dealing with a tumor that's blocking the intestine. You may need to treat the hypercalcemia, which is if that's the cause of the vomiting, that should then result in improvement of the vomiting, and so on and so forth. So really, you need to address the underlying cause. Lastly, there's empiric therapy. And by empiric therapy, I mean that there may not be an obvious underlying diagnosis up front, or there may still be, but we want to help the patient feel better. So we're looking at symptomatic treatment even while potentially treating the targeted cause. So empiric therapy, I'm really trying to focus on what are the symptomatic ways we can help the patient feel better, potentially even regardless of the underlying cause. And that goes back to looking at what is the pathophysiology of vomiting, what are the involved neurotransmitters, and that's why I focused early on those aspects of nausea and vomiting, because that will help us understand the pharmacotherapy. So many drugs that are used to treat nausea and vomiting work by blocking a specific neurotransmitter involved in the vomiting reflex, particularly dopamine antagonist and serotonin antagonists. And there are other drugs that may work by increasing motility in the gastrointestinal tract, and these are referred to as prokinetics. And this is something we've have or will just be discussing in other contexts as well. And that's really prokinetics focused on conditions in which there is impaired motility of the gastrointestinal tract, whereas the ones that involve dealing with the neurotransmitters in the vomiting reflex deals with multiple causes of vomiting. So looking back at that slide where we talked about the vomiting reflex being the common pathway, and then we think about the various inputs as well too. So for example, if we think of the chemoreceptor trigger zone where there's a predominance of dopamine 2 and serotonin 3 or 5-HT3 receptors, there are specific drugs that actually antagonize those receptors and may help vomiting if we think the origin of the vomiting is related to the chemoreceptor trigger zone. An example of dopamine 2 antagonists includes such things as we refer to as phenothiazines, an example being chlorpromazine. And then for 5-HT3 or serotonin 3 receptors, there's a common drug used in chemotherapy referred to as ondansetron, the brand name being Zofran. And again, the details in terms of the drug names is not so important at this point, but understanding that the pathophysiology or the physiology of how vomiting occurs and the neurotransmitters involved really do help you understand why pharmacotherapy, how the pharmacotherapy works. Another example, for example, the vestibular apparatus for which histamine 1 receptors and muscarinic 1 receptors may be important. So things like dimenhydramate, which is gravel, or scopolamine, which is often used for motion sickness, how those work based on those receptors. So this is a more detailed list of antiemetics using the neurotransmitter-based approach. Again, this is not for memorization by any means. It's purely for your interest. These drugs you'll learn about over time, particularly as you get into your clinical part of your training. This may serve as a useful reference for you. So we've talked about the top sort of 5 that are based on the neurotransmitters. There's a few I mentioned at the bottom just for your awareness. So corticosteroids are often used particularly in chemotherapy-related vomiting and actually has probably multiple effects in how it improves vomiting that probably are not even that well described. There's benzodiazepines, which are basically anti-anxiety drugs, which sometimes are used acutely and have various benefits, partly related to issues that maybe deal with input from the cortex. And there's cannabinoids as well too, and one notable example being nabilone. I do want to highlight one medication, which is metoclopramide, which is a dopamine 2 antagonist. And the reason I want to highlight this one is because it is also a prokinetic agent. So it works in the gastrointestinal tract by promoting motility. But due to its virtue of being able to sort of cross the blood-brain barrier, it does actually have more side effects and actually has more antiemetic roles as well too. So prokinetic drugs, just to review, these are drugs that promote gastrointestinal motility and thus really useful for situations in which there's impairment of gastrointestinal motility, such as gastroparesis. Gastrointestinal motility, both from a physiologic and clinical point of view, we often think of upper intestinal motility, so issues with the esophagus and stomach, and then lower intestinal motility, particularly the colon, in fact, and that the neurotransmitters involved can be a little bit different, and then the drugs we use are often tailored to whether this is an upper or lower intestinal or upper or lower gastrointestinal motility issue. But just to be aware of some of the important neurotransmitters, so here serotonin is still important, but there's actually a different receptor referred to as 5-HT4, for which the agonism, so the promotion of its activity, promotes gastrointestinal motility. And then there's dopamine 2 receptors as well too, for which the antagonism of this can actually improve motility, and something called motilin, particularly in the stomach, for which its agonism can promote motility. So again, these are just to review the common prokinetic drugs. So domperidone is relatively commonly used and acts as a dopamine 2 receptor antagonist, but it acts only peripherally. It does not cross the blood-brain barrier and thus really has very little antiemetic effect. And its clinical effect is mainly in the upper gastrointestinal tract. Metoclopramide, as I mentioned, is also a prokinetic agent that also has dopamine 2 receptor antagonist properties, but it can cross the blood-brain barrier and thus has more of an antiemetic effect than domperidone. But by virtue of its ability to cross the blood-brain barrier, it has increased risk of CNS side effects, including Parkinsonian symptoms and other concerning CNS side effects. And its clinical effect, like domperidone, from a gastrointestinal point of view, is mainly in the upper GI tract. There's a medication called prucalopride, which works on serotonin and that 5-HT4 receptor, which in the gastrointestinal tract promotes motility. Its clinical effect is mainly in the lower gastrointestinal tract, so used for things like constipation, but likely at higher doses may have some effect in the upper gastrointestinal tract. There's a medication called cisapride, which is also a 5-HT4 agonist, but it's not as specific for 5-HT4 in the gastrointestinal tract, whereas prucalopride is quite specific for 5-HT4 in the gastrointestinal tract, and thus cisapride's issue is its side effects, particularly its effect on the heart and its risk of cardiac arrhythmias. And because of cases of serious cardiac arrhythmias, it was removed from the regular market and is only available through special access programs. But its clinical effect is in both the upper and lower gastrointestinal tract. Erythromycin, which is a macrolide antibiotic, actually promotes motility in the upper digestive tract by acting on the motilin receptor. It's used very, very infrequently for this property, but also explains one of its side effects. So patients who often take erythromycin sometimes get quite a bit of upper digestive issues just because it's causing so much contraction of the stomach. But as I mentioned, it does work mechanistically, particularly acutely if someone has delayed gastric emptying from a bad flare of gastroparesis. But in sort of clinical practice, we actually use this quite infrequently. We generally rely on other medications. So now we've finished a module, so hopefully you should be able to define nausea and vomiting, describe the pathophysiology of nausea and vomiting, be able to provide assistance-based differential diagnosis for nausea and vomiting, describe general management for patients with nausea and vomiting, understand the role of empiric therapy for nausea and vomiting based on knowledge of neurotransmitters, and recall the role, names, and mechanism of action of prokinetic drugs. So this module is really just serving as a starting point for you to build on as you move through your curriculum and your training, as this will be something you encounter more and more, and we'll be able to build on this foundational material that this module provides. So I hope you've enjoyed this module, and we'll see you again soon.